Hello, everybody. Uh, Today we are going to talk about adrenergic and agonist and blocking drugs. So we know the general things about alpha and beta blockers. So we will not really go onto the anatomy and physiology. We are going to make some remarks only. Just remember all the classification of the nervous system between central and peripheral nervous system. Somatic, mostly they are going to use at the end acetylcholine, and autonomic is going to use the parasympathetic at the end cholinergic receptors, and the sympathetic is what we are using the adrenergic receptors with the adrenaline, sympathetic adrenaline. Okay, so we got that. So we already know all the preganglionics and the postganglionics, so the somatic and autonomic. So this is something I want you a little bit to remark here is here, this point, the adrenal gland. This is the source of our adrenaline and noradrenaline. It's called catecholamines and is in the medulla of the adrenal gland, right? So if you see here, that is sympathetic, sympathetic, sympathetic. Okay, so all right, so we already agree that the adrenal gland is going to receive acetylcholine, yes, but the resultant of the adrenaline of the sympathetic, because all these are preganglionic. Remember, preganglionics are all acetylcholine here in the sympathetic, but at the end they are going to just give adrenaline. So that is the adrenal gland. All right, so we have already all the effectors, the somatic and all. Okay, so here we will talk about the alpha A1 receptors, and for this I'm going to just make some remarks here that to summarize what we already know is the between alphas and betas. Okay, alphas and betas are distributed all over the body. Alphas mostly we divided in alpha 1, alpha 2. Remember alpha 1, vasoconstriction, alpha 2, vasodilation. And beta 1, one heart is going to increase the heart rate, adrenaline is going to increase the heart rate and the contractility of the heart, contractility of the heart. We have beta 2 agonist is going to be the bronchodilators. Okay, so talking about alpha 1 means agonist, right? I'm not going to say agonist. It's obvious that we said alpha 1 is agonist. Alpha 1 produce vasoconstriction, right? Vasoconstriction. So alpha 1 blockers produce vasodilation. Alpha 2 agonists are going to produce vasodilation. Alpha 2 blockers produce vasoconstriction. We have the beta 1. The beta 1 produce increase of the heart rate and contractility, and beta 1 blockers are going to decrease the heart rate and the contractility. So they're doing the opposite. So that's why, for example, beta 1 blockers we are going to use in that is going to be used to decrease the needs of oxygen of the myocardium, and that is used in heart failure. That is beta 1 blockers. All right, so beta 2 we have bronchodilators, and beta 2 blockers. There's no medications actually can are being medical use in medicine. Okay. All right, so let's keep going and review here. One thing here, we have the blood pressure. The blood pressure. So mostly of these medications, what are going to do is to treat hypertension and heart failure. Hypertension and heart failure. So we have the blood pressure, we have the peripheral resistance and the cardiac output. Peripheral resistance increase when you have vasoconstriction. When you have vasodilation, the peripheral resistance go down. It's easy to flow if you have more dilated vessels. Cardiac output is related to the frequency and the stroke volume or volume. The frequency is the heart rate, and the stroke volume is the venous return. is the venous return. Venous return means the blood coming towards the heart, arriving into the right atrium, and then go the pathway, right? All right, so then after this, when the blood is arriving into the cavities, we have that the heart will distend the cavity, right? The cavity will distend. And that is because it's receiving this load of blood, of venous return. That is called the preload. Preload. Preload is the blood volume that distend the ventricles. And that is diastole, right? And then when the more volume you have, the more contraction is going to happen. So that is the afterload. So diastolic volume, systolic is the strength of the contraction, contractility, okay? So systolic is not related to the volume. Systolic afterload is related to the how strong is the contraction of the muscle, the ventricle. So peripheral resistance, mostly we have the alphas, what we are going to use in peripheral resistance, alpha 1, right? Alpha 1 blockers, right? Alpha 1 blockers to decrease the blood pressure. If you have the blood pressure high, you want to decrease the peripheral resistance. So what you're going to do is to promote the vasodilation. How you promote the vasodilation? You have alpha 1 that produce vasoconstriction. So we don't want that. So we want alpha 1 blocker that promote the vasodilation. On the other hand, we are going to use alpha 2 agonist to decrease the peripheral resistance. If we want to decrease the peripheral resistance, we can use alpha 1 blockers or alpha 2 agonists, right? So that is going to be the alphas. Meantime, if you can tell, the alphas mostly work in the peripheral resistance. Meantime, the betas are going to work in the cardiac output. Not in the, they are going to exactly work in the stroke volume. They are going to work in the contractility, beta 1 blocker, for example. They are going to work in the contractility and the heart rate. In decreasing the heart rate, you can see blood pressure go down. The stroke volume is going to be affected because the beta 1s are going to diminish the contractility of the stroke, so the afterload. So that's why it's very good to use in heart failure. In heart failure, it's going to decrease the contractility, decreasing the stroke volume, decreasing the cardiac output, and decreasing the blood pressure. So having this introduction, we are going to start talking about more specifically about medications. But before this, we have the sensitivity of these adrenergic receptors to the epinephrine. We have beta 2 is more sensitive to adrenaline than beta 1, and beta 1 more sensitive to alpha 1. So if you see here beta 2, you're going to have, for example, the albuterol is a bronchodilator, right? So beta 2 is alone, so it's agonist, right? We're talking about agonist. Beta 2 is a bronchodilator, the albuterol, for example. But if you give too much albuterol, this albuterol can lead into stimulation of the beta 1. So that means tachycardias. So that can increase the heart rate, for example. All right. So let's talk about the these are the medications, the norepinephrine. So we are talking about agonists. They are going to medications that stimulate the alphas and betas. Okay, adrenergic drugs. So the norepinephrine, as you can tell with the adrenaline, we have norepinephrine, adrenaline, and dopamine. All these guys are going to be called catecholamines. Norepinephrine, adrenaline, and dopamine, they have different behavior. When they act at the level of the central nervous system, they have a different behavior from the peripheral nervous system. So what we are going to talk in this part of the class is that the effect on the peripheral nervous system, in the peripheral area, okay? So norepinephrine, adrenaline, dopamine, those guys, especially adrenaline, noradrenaline, are going to increase when you become upset or excited, or all these are going to produce the stimulation of the alpha 1, stimulation of beta 1, and stimulation of beta 2 especially. Why I didn't mention alpha 2? Because mostly all these adrenergic are going to affect, first of all, alpha 1. They need to have excess of adrenaline, or highest amount of adrenaline or adrenaline, to affect the alpha 2. So if you have some amount of adrenaline, the first that is going to be affected is alpha 1s. Okay, a comparison between alpha 1 and alpha 2. All right, so here we have the heart rate is going to increase. Okay, so increasing the heart rate means that it's going to increase the cardiac output, and that is going to increase the blood pressure, right? Produce bronchodilation and increase the blood pressure. So this is norepinephrine. Dopamine. Dopamine is going to, so noradrenaline increase the blood pressure. Conclusion. Dopamine is going to increase the blood pressure too. And basically what is going to happen is the vasoconstriction. So you can see the difference. Norepinephrine increase the heart rate. Here the dopamine is mostly going to produce vasoconstriction. So the peripheral resistance is going up. The dopamine is going to increase the heart rate. So in general, norepinephrine for different pathways and dopamine in different pathways are going to lead into the increase of blood pressure. When we are going to use that, obviously when you have hypotension, right? Hypotension. All right, so let's go here. We have, for example, for asthma and bronchitis. So what we are going to use? We are going to use agonists, right? Which agonist? The beta 2 agonist. Beta 2 agonist. The bronchodilation. Mostly it's going to be the albuterol. We have the ephedrine. Ephedrine is similar to the epinephrine, this guy, but the problem is that this can lead into a bronchodilation, but stimulate to the heart rate, so they can have some tachycardia. Albuterol is bronchodilator mostly for beta 2. Ephedrine is mostly for beta 1 that can affect to beta 2. But here, albuterol is the one who we select for bronchodilation, especially. Treatment of remember the organs, they have different amounts of alphas and betas. So, for example, the lungs, they have more number of beta 2 receptors. So that's why albuterol is effective in the lungs. Treatment for nasal congestion. So we have alpha-1 adrenergic agonists. Ephedrine, can you see ephedrine here? Ephedrine. So in those situations, nafzoline, oxymetazoline, phenylephrine, tetrahydrozoline. So all these are alphas, alpha adrenergic receptors. So you can tell nasal congestion. What is the cause of nasal congestion is allergies, right? For example, allergies or some inflammation caused by a virus that produce the activation of the basophils, mast cells, and they release a lot of histamine. Histamine produces vasodilation. So this vasodilation is going to lead into congestion. Why? Because during the vasodilation, water, the vessel is distended, so water is more permeable to escape from the blood into the surrounding tissue. So that's why all the mucus of your of the pharynx, nasopharynx example, are going to be swollen, blocking the pathway of the air. So what we are going to try to do is to take decongestants. And decongestants are going to be vasoconstrictors, who are alpha-1 agonists. So alpha-1 agonists are vasoconstrictors, so they are going to decrease the nasal congestion. Conjunctival congestion is, we have the phenylephrine, nafzoline, and these are actually what they are doing is red eye, right? What is your red eye? The red eye is vasodilation of the vessels, of the conjunctiva. And that is because allergies, mast cells again, they're going to release histamine, vasodilation, and that is going to produce the red eye. So we are going to use vasoconstrictors. Those are the alpha ones, okay? Agonists. Reduction of the intraocular pressure, that is mostly used in open glaucoma. Please, I said open glaucoma, no closed glaucoma. In closed glaucoma, we are going to use diuretics and laser. But in the for adrenergics, we are going to use mostly alpha agonists for open glaucoma. Who is worse? Is the closed glaucoma is worse. Open glaucoma is in the most common is 80% of cases are open glaucoma, 20% are going to be closed glaucoma. So we use alpha adrenergic to reduce the intraocular pressure. So that means that they're going to decrease the production of the aqueous humor in the anterior and posterior chamber. That is going to be the treatment. And the people, these patients need to take these medications topical, of course, is ophthalmic drops are going to be forever, for the rest of their life. Okay. All right. So let's keep going. All right. So we have the butamine. The butamine is similar to is beta 1 selective. So selective is similar to the dopamine. It's going to increase the cardiac output and increase contractility. So it's going to have a positive inotropic effect. Positive inotropic effect. And that is using for heart failure. Dobutamine, heart failure, right? So contractility. Why the heart is not able to pump? So that is going to increase the contractility. All right, so the dopamine has different effects. The main is entropy, and in low dosages that can lead into vasodilation. So we need to the dose need to be standardized. So a certain dose where what we want is to increase the blood pressure. So in this case, we are going to give a dose that is going to increase the contractility and the output. Dopamine can be used for for example, in low doses when you want to increase especially the blood supply to the GI tract, to all the intestines, small and large intestines. There is some ischemia there for some reason. Dopamine in low dosages are going to be useful. Same for kidneys. The kidneys in these low doses, when they are low perfusion, low amount of blood into the kidney because probably some renal artery stenosis, they are going to increase the blood flow to the kidneys. Okay. All right. So let's keep going. So we have epinephrine. Epinephrine is going to be used for anaphylaxis, right? Anaphylaxis means a systemic reaction where the vessels are going to completely vasodilate. All the vessels for the body, anaphylaxis. So you slow down the blood flow, you lose consciousness because they cannot reach the brain, and even 1 second or less than 1 second of lack of blood supply, the person faints. All right, so here we have 1 over 10,000. 1 over 10,000. So please, I want just you to know this 1 means 1 gram over 10,000 mLs. So let me see if I can write it down because the mouse is unfortunately was broken. So let me see if I can do no, sorry. I have problems always with the pointer. Sorry for that. Okay, so the pointer is not appearing here. All right. So anyhow, so we have, remember, please take a pen or a paper and put here 1 gram, and here is 10,000 mLs. Okay, is 1 gram is equal to, say, 1,000 milligrams, right? 1,000 milligrams. So if you can put here 1,000 milligrams and 10,000 mLs here, 1,000 milligrams, you divide all the zeros, you're going to have 1 milligram every 10 mLs. If you divide it by 10 again, that is going to give you 0.1 milligrams per ml. So that is what is telling you this number. Okay, so you divide, take all, well, we have 1,000 milligrams, take 3 zeros, and take 3 zeros like here. So we have 1 milligram and 10 mLs. Divided by 10, both of them, you have 0.1 milligrams over 1 ml. All right, so hopefully that is helping a little bit, because I saw some have some difficulties for this. All right, so let's keep going. All right, so let's keep, this is the, okay, so here's one of the mirabegron. It's a beta adrenergic agonist. It was relaxing muscle of the urinary bladder. So this, besides that, the betas can produce they can produce some muscle relaxation. So the beta one, they can lead into beta relaxation too. So it's not, we talk about heart rate and contractility, but in addition to that, can produce muscle relaxing. And that is mostly we use in urinary bladder, overreactive urinary bladder. So that is the mirabegron. Okay, it's English. Okay, so glaucoma we are going to see another time. We have A and B's, so A, B, C, D. So A is alphas, beta, there are going to be beta blockers, and they are going to decrease the production of the aqueous. So that is, we have the timolol especially. Timolol is very, very useful for this this treatment. Okay. All right, so let's see here. Interactions of the alpha agonists are going to be anesthetic drugs. So interaction, what is interaction? One is depressor and the other is stimulant, right? So because adrenaline, noradrenaline, dopamine are stressors, are stimulants. Meantime, anesthetic is going to do totally the opposite. So they are going to be uh, doing the opposite, antagonist, right? Sometimes we need the adrenaline in case of situations where the heart rate drop very much. So, or too much anesthesia, the patient is totally depressed, they can lead into asystole, so heart attack, in other words. And in that case, we are going to need to use definitely an antagonist, that is the adrenaline. Mouse, we talk about this in Parkinson. If you give it together, so what is nursing considerations? Everything that you can imagine. No? Patients who are having hypotension, they have Parkinson. Another situation, patients who have a simple cold and they use alpha agonists in order to decrease the congestion of the nasopharynx, right? So we have the 3 cyclic antidepressant that is coming in the next module, in the next, no, there's no module, in the next lectures are going to be for antidepressants, 3 cyclic, that can lead into hypertension crisis. They are going to the antihistaminics and the alphas, they are going to have opposite effect, they are going to be antagonists. And thyroid preparations, T3 and T4, right? So people who are receiving Cytomel, for example, T3 or some medications that increase the levels of T3 and T4, they can lead into a crisis of hypertension. Why? Because T3 and T4 increase the metabolism of the body. And that is going to be the interaction, okay? All right. So salmeterol. Salmeterol is a beta 2. All right. So I want you to remark this name, salmeterol, indicated for prevention of bronchospasm. So that is going to take uh, few days in order to start to make effect. So it's not going to be immediately, but it's going to be mostly used for prevention. We have, for acute process, we have what? The albuterol. All right, so let's talk about adrenergic blocking drugs, and we have the alpha blockers. We already talked about alpha 1 vasoconstriction. Alpha 1 blocker promote vasodilation. Alpha 2 produce vasodilation. Alpha 2 blockers can lead into vasoconstriction. Beta 1 agonists produce heart rate and contractility, and alpha and the beta 1 blockers the opposite, decrease the heart rate and contractility. And the beta 2, we have bronchodilators, and there's no uses for beta 2 antagonists. There is one medication that is called Jombin that is mostly used for, it's not applicable for humans, it's mostly in the veterinarian use. Jombin. Jombin is Yombine. All right. So let's talk about I want just to go over the alpha blockers. Number one, please. Number one, the main use of alpha blockers. Alpha blockers, try to put your mind in alpha blockers. Alpha 1 blocker, what is going to do? Promote vasodilation, right? Alpha 2 blockers is going to produce blockers promote the vasoconstriction. It's the opposite, right, of the agonist. All right, so here we have the main use for alpha blockers are going to be the hypertension. Second, produce vasodilation, right? Vasodilation. Why? Because they mostly work at the level of the smooth muscle of the vessels. Okay. We have two types of alpha blockers: the non-selective and the selective. The non-selective are, please, you can write down in your PowerPoint. Is the non-selective is the phentolamine. You can see in the screen. Phentolamine. I cannot write it down because I don't have the pointer. Oh, let me see. No, I don't have it. Okay. So let me see if I. Okay, the phentolamine is going to be the non-selective. Non-selective. And the pen is not working. Okay. No selective. Okay, this is no selective. Okay, no selective. Okay, I cannot print it right now. Okay, anyhow. So here we have phentolamine is no selective. So what is important about the phentolamine? So please, this is full NCLEX, okay? Phentolamine is used for hypertension, but is used in hypertension for people who suffer from pheochromocytoma. Pheochromocytoma, it's writing in your notes. Pheochromocytoma. Pheochromocytoma. Pheochromocytoma is a cancer of the adrenal gland medulla. Again, phentolamine pheochromocytoma. Okay, just to remember, phentolamine starts similar. Phentolamine pheochromocytoma. So treat the hypertension. And that is going to be alpha blocker. So especially alpha 1 blocker, right? So alpha 1 blocker. Alpha 1 produce vasoconstriction. Alpha 1 blocker produce vasodilation. So that is the rule for, no rule, but just to remember about NCLEX, please. Phentolamine pheochromocytoma. What is this guy? It's no selective. If I tell you it's no selective, they can block secondary the alpha 2. So we have some range of those for this phentolamine. This guy is actually reversible, is reversible in about 4 hours. All right, so that is about the phentolamine. that is, first of all, remember, is no selective, please, no selective. I'm using my no. Okay, let's keep going. All right, so that is the phentolamine. One thing is that another use that we have the phentolamine is the extravasation of vasoconstrictor drugs. So if you have inoculation of IV or intramuscular, whatever is giving the adrenergic agonist, what they are going to do is vasoconstriction of the vessels. And when this substance is getting spread on the tissue, especially connective tissue like fat and muscles, they can produce vasoconstriction, ischemia, and necrosis. So phentolamine is going to be used for that, okay? And pheochromocytoma, don't forget about that, okay? Tamsulosin is alpha-1 blocker, relaxes smooth muscle of the prostate and the bladder, neck. So tamsulosin is going to be used for BPH, benign prostatic hypertrophy. Benign prostatic hypertrophy. After 50, prostate start to enlarge. The reasons, we don't know. And BPH is going to block the urethra, the exit of the urine from the urinary bladder. So the prostate, they have a portion of in the prostate, they have a smooth muscle. That prostate, that smooth muscle has the function that during the ejaculation is going to literally squeeze the rest of the prostate gland in order to release the prostatic fluid. Okay, so that is the part of the muscle that is going to be having hypertrophy. All right. So what they are doing this tamsulosin is to decrease the relax the muscle of this portion of the prostate and produce the is able to not compress the urethra anymore. And they are going to just relax the smooth muscle of the urinary bladder too, so close to the prostate. All right, so we have beta blockers, and beta blockers we have are indicated for heart failure. It's indicated for angina. They have cardioprotective. It's cardioprotective because it's going to decrease the incidence of myocardial infarction. Okay, so here we have about the beta blockers. The beta blockers, we have the non-selective and the selective. Okay, so here we are going to stop a little bit because it's important to make some considerations here. Number one, we have, and please, I would like you to write it down. Non-selective means that beta blocker can block beta 1 and beta 2. Correct? Propranolol Inderal is the prototype. What is going to decrease is the heart rate and the contractility, correct? Okay, so we must know that. And please, if you don't correlate with the image of blood pressure, resistance, peripheral resistance, cardiac output, etc., you cannot have an idea of how to memorize, to remember this medication. So you must go first to that chart, and when you learn that chart, you start to, every medication you are talking about, try to imagine that image in your mind and try to apply the algorithm with the medication. That is the way that is going to stick with in your mind. Okay, so propranolol. So one nursing considerations and NCLEX question is that besides that it's being used to decrease the blood pressure, to decrease the incidence of myocardial infarction, decrease the consumption of oxygen by the myocardium, they are going to decrease the conductivity The conductivity means that they stimulate less the sinusal node or the atrial ventricular node. So all this is going to make decrease the blood pressure and the oxygen needs for myocardium. This is the point. Propranolol, this is one. And the second, what I want you to know about propranolol is that this propranolol is able to pass the central nervous system. And this is used, for, they can use as a prophylaxis for migraine. Propranolol can be used as a prophylaxis for migraine. We have other medications that can be used. For example, the verapamil, they are going to be used too for migraine. But propranolol, let's say in propranolol, can be used for whatever we already talked and the prevention of the migraine. We have we have the timolol here. There you are. The timolol is something I want to make emphasis here. That timolol is the blockadrin optic, right? So timolol, if we have timolol is going to be used as eye drops for decrease the intraocular pressure. It's going to decrease the intraocular pressure. So if you see here, these guys, the pindolol, nadolol, that guy, are going to be mostly non-selective, so they can give you side effects. So it's not selective, means that it's going to block primary beta 1, but they can block beta 2. So all these guys can lead into what? Into wheezing, bronchoconstriction. We have the cardioselective block medications. We have the atenolol, and we have the metropolol, esmolol, okay? And this, because it's cardioselective beta blocker, so mostly it's going to, not mostly, it's going to be selective for beta 1. It's not going to affect beta 2. If they don't affect beta 2, these guys can be used for people who are suffering from chronic lung diseases like COPD, asthma, emphysema. And these guys, on the other side, that no selective beta blockers are going to be contraindicated for patients who are having asthma or some another chronic lung disease, restrictive or obstructive lung disease. All right, so here we have the carvedilol and metropolol are mostly used for heart failure. Okay, so all right, so one thing, let's see. All right, so here I just want to finish this lecture, because here we have the question that we was talking about. A patient with diabetes type 2 is taking beta blocker as part of treatment of hypertension. Which complication is most likely happen? So this is type 2 diabetes. It's not beta 2 blocker. Okay, this is beta 1 blocker. And remember, we was talking about beta 1 blocker is about the renin. Okay, it's the renin. So what is doing the diabetes type 2 and beta blockers? For example, we are having the propranolol. So what is doing is that the beta blocker are if you increase beta 1 blocker, if you increase the dose, that is going to decrease the levels of insulin. If you go to the formula, and let me see if hopefully I can write down something here, just a moment. All right, so let's see. We already know that beta 1 and alpha 1 is about the renin, right? Renin. So that is talking about hypoglycemia, right? So now beta 2 and alpha 2 are going to be for insulin, right? Insulin. I put I, hopefully can write down here something. insulin. Insulin. Okay, insulin. So beta 2 is going to increase the insulin, and alpha 2 is going to decrease the insulin. So let's focus on beta 2. Beta 2 agonist is going to increase the insulin. So beta 2 blocker are going to decrease the insulin. If you decrease the insulin, the sugar cannot get into the cell, so sugar go up. Okay, so and that is what happened. We are talking about beta 1. Beta 1 is not selective, and the beta 1 can, in high doses, can lead into beta 2 blocker here, decreasing the insulin. So that is going to increase the sugar, the glucose in blood. So that's why it's telling you that you have hypoglycemia, and the patient in diabetic hypoglycemia, if you have this situation, that is going to block the insulin, increasing the insulin, hiding the signs and symptoms of hypoglycemia. So hiding the signs and symptoms of hypoglycemia. Okay, so that is about for this class. So please, thank you so much. I will open microphones, and if there is any question, please let me know now. I'm going to open just a moment. Alicia, can you hear me?
Hello?
Yes, any question?
Nope, no questions.
Okay. David, any question? You unmute yourself. You just mute yourself. Deepika, thank you. Any question?
No questions, Dr. G.
Okay. Joan Lozano? Joan?
No, no question.
Okay, Joan, thank you. Michelle?
Yes, Dr. G.
Okay. And David? Okay, David, probably he's not able to
The phone.
microphone. All right, thank you so much. I will see you next time, and I hope that is a bit in your
Thank you, Dr.
preparation
G.
for your exam. Muchas gracias.
Thank you.
Thank you.
Thank you.
Bye bye, girl. Thank you. Bye.
Bye. Good night.
Good night.
खुदा ये बता